Good morning. Welcome to our webinar this morning titled Winter Season Preparation, Infection Prevention and Control in Personal Care Homes and Assisted Living Residences. Today we will have Dr. Jane Gould, who's a public health physician consultant for the Pennsylvania Department of Health, Bureau of Epidemiology. But before we get started, I'd like to go over a few things so you know how to participate in today's event. You'll be listening to the presentation via your computer speaker system by default. If you prefer to join by phone, select the telephone button in the audio pane, and the dial-in information will be displayed. And you'll be in listen-only mode to hear the presentation. You may submit questions via text by typing your questions into the question pane of the control panel, and you may send your questions in at any time during the presentation. Also, please note we can't see the questions in the room where we are, and the webinar administrator will be printing them out and bringing them into us as we go along. And we plan to cover most of the questions at the end of the presentation. We'll only be addressing questions relating to today's topic of infection control. Any other questions can be directed to the operator support hotline at 866-503-3926. Or you can email the operator support hotline email address at ra-pwarlheadquarters@state.pa.us. And this information is also available on our website. We have one handout available for today's webinar, which is the PowerPoint presentation we're using today. It's available in the options menu. If you open the options menu and then click on the plus sign next to the word handouts, a box containing the handout will appear and you can access it there. So now I'm going to turn the webinar over to Dr. Jane Gould to talk about infection control.
Thank you. Good morning, everyone. So the title of my presentation is Winter Season Preparation, Infection Prevention and Control in Personal Care Homes. I must disclose up front that my husband works for Insight, but I will not be speaking about any Insight products. This is a list of some of the abbreviations that we'll be using throughout the talk, and I'll define them as we go along. So the objectives of my talk are to review winter season pathogens. So these are pathogens that are more prevalent during the winter season, such as influenza, Group A streptococcal infections, norovirus, and Clostridioides difficile-associated diarrhea, also known as C. difficile diarrhea. We will also discuss transmission and infection prevention to prevent transmission. We'll discuss the environment of care, the importance of hand hygiene and respiratory etiquette, the use of personal protective equipment, and issues related to employee health. So let's review why personal care homes have a higher infection risk. So the patient population is typically more vulnerable to infections because of aging or poor health, mental and physical disabilities. There's the group setting in which residents are situated in close proximity to one another, eating in the same facility, and having frequently touched surfaces throughout the facility. There's also high-risk circumstances that might be happening in the facility, such as in-house blood testing, increasing the risk of bloodborne pathogen transmission. There are sick residents and visitors often, especially during winter respiratory viral season, and residents returning from the hospital. So why is infection control important? Well, so there is an overall impact on census if there's poor attention to infection control. This can decrease the number of occupied beds, either because acute illnesses in residents lead to hospital admissions, or acute illnesses can exacerbate comorbid conditions, also necessitating a hospital admission, and those illnesses can then cause death. And we know that persons from personal care homes and long-term care facilities have a higher risk of death secondary to influenza and to Clostridium difficile. Additionally, the need to isolate residents because of illness can also impact on the available beds in your facility. Likewise, it can have a negative impact on your institutional reputation if you have an infection control outbreak. So there are public relations ramifications. Consumers are now very educated, and a dissatisfied consumer will talk about a facility in which their loved one contracted an infectious disease. And facility-acquired infections are not evidence of good care. They are reportable incidents to the state. And they can also lead to legal action and news reports, which would be a negative. So I would just like to remind everyone about the Pennsylvania State Code requiring infection control training of direct care staff, and this must occur annually. This is a list of the reportable diseases in the Pennsylvania Code, and this includes some of the pathogens that we will be discussing today, and you can access this list of reportable diseases at this website on the slide. Most of these diseases are reportable within 5 working days, and of course all outbreaks or unusual events are reportable. So what is an outbreak? It's an occurrence of cases of a disease in excess of what would normally be expected in a defined community or a geographical area or in the season of interest. This may occur in a restricted geographical area or may extend over several countries. A single case can be considered an outbreak when it is a communicable disease that's long been absent from a particular population and now has resurfaced, or it's caused by an agent that's not previously recognized in that community or area, as well as an emergence of a previously unknown disease. So outbreaks do occur in personal care homes and assisted living facilities. This is an example of an outbreak, and it was associated with Streptococcus pneumoniae, causing pneumonia and bloodstream infections in residents and in one staff member. During this investigation, the Colorado Department of Public Health identified several infection control deficiencies, such as employees were not aware of their sick leave policy and its role in infection control, so they came to work while sick. The facility did not have written infection control policies for maintaining personal protective equipment, such as gowns and face masks, that would have prevented staff from becoming sick and from spreading it to other residents. And staff members were not educated about personal protective equipment use, also abbreviated PPE. So this is a table of CDC data from long-term care, from assisted living facilities, skilled nursing facilities, personal care homes, and rehab facilities of outbreaks that occurred between 2010 to 2013. And there were multiple states involved. Let's see, yeah. So you can see multiple states involved. Up here is the number, and these are the respiratory pathogens that caused outbreaks. And you can see that there were, if you total these up, about 335 respiratory outbreaks. The ones in yellow are the respiratory pathogens that we're going to talk about today. Next is the number of GI pathogens, and there were over 1,000 GI outbreaks. Many were secondary to norovirus, which we're going to talk about today. There is also a C. difficile outbreak in a facility in Virginia. In 2018, Pennsylvania had 127 outbreaks of norovirus in facilities with greater than 3,000 cases, so a significant burden of disease. The last two columns here have the number of miscellaneous pathogens, but Streptococcus pyogenes, also known as group A strep, is one of the organisms that we're going to discuss today. So let's talk about group A strep outbreaks. Okay, so this does happen, unfortunately, and this is a CDC Morbidity and Mortality Weekly Report, MMWR report, entitled Invasive Group A Streptococcus in a Skilled Nursing Facility in Pennsylvania from 2009 to 2010. And what this analysis revealed was that there were 13 cases of invasive group A strep, abbreviated GAS. All these patients required hospitalization. There were 2 deaths as a result of the invasive group A strep infection, with a case fatality rate of 15%, so high morbidity and mortality, and 10 non-invasive cases. So the non-invasive cases were limited to respiratory tract, wound, infections, or eyes. So invasive was either like pneumonia, bloodstream infection, meningitis, things like that. The case patients were found to be significantly more likely than the control subjects to have 2 or more wounds. And again, multiple infection prevention deficiencies were identified, including ineffective hand hygiene with a compliance rate of only 32%, and inadequate hand hygiene supplies in the facility, as well as very poor wound care practices. And I think I would like to stress that a single case of group A strep invasive disease should be reported and investigated. So who should you call if there's a cluster of infections occurring in your facility? If you live in a jurisdiction that has a local health department or a district office, you should contact them first. The local or district office will then contact the State Department of Health as needed. And we do have a healthcare-associated infection prevention and antimicrobial stewardship team within the State Department of Health that will help you with getting your outbreak under control to limit the number of patients or residents that get affected. Okay, so now let's move on into the winter season pathogens. Those that are spread by respiratory transmission that we'll be talking about today are the common cold viruses, influenza, and group A streptococcal infections. Those that are spread by gastrointestinal transmission, which we'll be discussing today, are norovirus and Clostridioides difficile. That's a new name. All used to go by the name Clostridium difficile, but we'll just call it C. difficile for ease. Okay, so I'd like to stress first the importance of the environment of care and the transmission of all of these pathogens that we'll be discussing today. So this table shows how long nosocomial viral pathogens will persist on an inanimate surface. And so right here, influenza virus, you can see it will last 1 to 2 days on a dry, inanimate surface. Norovirus, 8 hours to 7 days. Rhinovirus, which is the typical virus causing an upper respiratory tract infection or cold, 2 hours to 7 days. So you can see that these viruses will persist in the environment for a long time if the environment is not cleaned and disinfected properly. This table reveals the clinically relevant bacteria and how long they will persist on a dry, inanimate surface. And you can see the ones we're going to talk about today. C. difficile spores can last up to 5 months on a dry, inanimate surface. And Streptococcus pyogenes, also known as group A streptococcus, 3 days to 6.5 months if the surface has not been cleaned and disinfected properly. So a contaminated surface then can contaminate hands, and contaminated hands can transmit the infection to residents, colleagues, or other staff, and they can bring it home to their families. All right, so now let's talk a little bit about common cold viruses. So these can be transmitted to residents by direct care workers or by visitors or by other residents. Debilitated residents are much less able to cope with common respiratory viral illnesses. This might be because of pre-existing respiratory disease, such as COPD or chronic obstructive pulmonary disease or emphysema or asthma, things like that. They might have immune system dysfunction that would make it more likely for a virus to cause more severe illness. And seemingly mild illness can take much longer to resolve. Respiratory viruses are typically spread by droplet transmission. So these are large droplets that remain suspended in the air for only short periods of time and then fall and land on surfaces. So droplet transmission is easier to have occur in close quarters. Patients who are residents who are sneezing and coughing are expelling droplets, and these will then condense out onto surfaces. So it's easier to transmit in close quarters with dense populations and multi-touch surfaces that have not been cleaned and disinfected properly. So it's very important for staff and residents and visitors to practice good cough, cold etiquette and hand hygiene, which we're going to talk about later in the talk. So now influenza. So the first is data from the United States. So there are approximately 226,000 hospitalizations per year in our country secondary to influenza, and on average about 23,000 deaths per year. Most of these deaths occur in persons older than 65 years of age. In the world, there are about 3 to 5 million cases of severe influenza illness every year, and 250,000 to 500,000 deaths per year. So a significant burden of disease and waste of resources in these infections. Symptoms can include fever, headache, cough, myalgias, and you can see secondary bacterial pneumonias in patients with influenza. You are infectious 24 hours before symptoms start, but your ability to shed the virus typically peaks in the first 3 days after symptoms begin and typically will stop by 7 days. However, people who are immunocompromised because of either disease or extremes of age can have prolonged shedding of the virus. The virus is being shed for longer periods of time, and the surfaces in the facility can remain contaminated for longer periods of time. And spreading from person to person is primarily obtained by respiratory droplet or contact with contaminated surfaces. So influenza can be prevented by annual vaccination of residents and direct care workers. Also, direct care workers and staff should practice not coming to work when sick, which is also called presenteeism. So when somebody comes to work when they're sick, they can spread influenza or respiratory viruses, whatever they might be sick with, to residents and colleagues. It can also be prevented by practicing excellent cough-cold etiquette and personal protective equipment usage, and by practicing excellent hand hygiene and environmental cleaning. Okay, next we're going to talk about group A streptococcal infections. So group A streptococcus is a bacteria that's found often in the throat and on the skin, and typically most of the time people are asymptomatically colonized with the bacteria in those locations, and it doesn't cause any problems. If it is going to cause a problem, it's typically a mild illness such as strep throat or impetigo. But those who have increased risk of more severe infections from group A strep include those with chronic illnesses, diabetes, chronic heart and lung disease, those who are immunocompromised, let's say by cancer or from medications such as steroids, those with skin lesions such as open cuts or people with chicken pox and surgical wounds, those who are elderly, people who live in a congregate setting such as personal care home or nursing home, homeless shelter, jails or correctional facilities, and child care centers. People with a history of alcohol abuse or injection drug use are also at increased risk for severe group A strep infections. So luckily, it rarely causes invasive disease, but 11,000 to 13,000 cases per year in the United States is still a lot, and it is preventable by good infection prevention. These invasive infections every year cause about 1,100 to 1,600 deaths. I think it's also important to note that persons with strep throat can spread to others until 24 hours after they've received antibiotics, or for 10 to 21 days if they do not receive antibiotics. This is a CDC study of invasive group A strep infections in the United States from 1998 to 2003. And these were persons who resided in either a community residence compared to those in a long-term care facility. And what they found was that those that lived in a long-term care facility or congregate setting had more bacteremia secondary to group A strep and more pneumonia, and they were 1.5 times as likely to die of that infection as those that lived in the community. So high burden of disease and significant mortality. And in multivariate logistic regression analysis, long-term care facility residence was an independent predictor of death. So this is a chart abstracted from the Pennsylvania Department of Health Group A strep fact sheet, which is available at the website listed below here, www.health.pa.gov. And this is about the infection control precautions for group A strep disease, depending upon the infection type. So on the left part of this table is the infection type. So wound, a burn, or a skin infection versus respiratory or invasive disease. So if the dressing covers and contains the secretions, the only precautions needed are standard precautions, which means that when you're going to go and touch the wound, you need to use personal protective equipment and perform good hand hygiene. If the dressing is known to not contain the secretions, then it's recommended that more precautions be used, such as droplet and standard precautions. That means upon entry into the room, you should wear gowns and gloves and mask if you think you're going to come in contact with the secretions. Additionally, for respiratory infections due to group A strep, it's recommended, again, droplet and standard precautions, and to maintain those precautions until 24 hours after the initiation of effective antimicrobial therapy. So if you are a direct care worker and you're going to come in contact within 3 feet of somebody with group A strep, pharyngitis, or pneumonia, then you should be protecting your own mucous membranes with a mask, in addition to gown and gloving. Okay, this is also from the same Pennsylvania Department of Health website in their Group A strep fact sheet. This is a wound care checklist, and use of this checklist will help prompt direct care workers to perform proper infection prevention practices when caring for a resident with a Group A strep wound. This will decrease the chances of transmission If you go to the fact sheet, you'll have more information, but I would recommend trying to utilize a checklist like this to prompt your staff to perform proper infection prevention. It's also, I wanted to mention, it's also possible to decolonize asymptomatic carriers. And if your facility is having a group A strep outbreak, the public health department might recommend doing culturing of asymptomatic persons to see if they're colonized or carrier. And then antibiotics can be used to eradicate that colonization or the carrier state so that those persons don't get invasive disease themselves or spread to others. So before we go to norovirus, I just want to mention it is important that if you have group A strep in your facility, that you contact your local or state health department for assistance. Okay, next pathogen we will discuss is norovirus. Norovirus is a leading cause of gastroenteritis in the United States, caused by a virus. Causes vomiting and diarrhea, usually lasting about 1 to 2 days. Can also see fever, malaise, anorexia, and headache. There is person-to-person transmission in the typical fecal-to-oral route, and that is through contaminated food, water, or contaminated surfaces. Norovirus can be shed in the feces for 2 or more weeks after a person feels better. So even though they're better, the virus is still being shed in their feces, and so meticulous hand hygiene, if you're helping residents with toileting, is indicated. Outbreaks can occur with very high attack rates in semi-closed populations, such as personal care homes and assisted living facilities. So some infection prevention things that you must remember with norovirus is that you have to use soap and water for hand hygiene. And that's because the virus is not inactivated by the alcohol in the alcohol-based hand rub. Okay, so you must use soap and water. Additionally, the quaternary ammonium compounds that are typically used to clean healthcare facility environments will not inactivate or kill norovirus. So we must use either chlorine bleach or an EPA registered disinfectant that you can find on the K list if you go to the EPA website. EPA is the Environmental Protection Agency. So we need that product to have a kill claim against norovirus in order to clean properly your environment if you should have a norovirus outbreak. So what is the definition of a norovirus outbreak in a post-acute care facility such as long-term care, skilled nursing, rehab, acute living facility, assisted living facility, a personal care home, and an immediate care facility? So that definition is greater than or equal to 2 cases that either meet a confirmed or probable definition of norovirus. In which case, if that's the situation that you're experiencing in your facility this winter, you should contact your local health department to report the cases and to get assistance. The local health department or your facility can also contact the Pennsylvania Department of Health to also discuss infection control recommendations to get your outbreak under control. The last organism we're going to discuss is Clostridioides difficile, or C. difficile. This is a spore-forming gram-positive anaerobic bacillus. It accounts for 15 to 25% of all episodes of antibiotic-associated diarrhea. So why is C. difficile important? Well, again, alcohol does not kill C. difficile spores. So if you're using alcohol-based hand rub as the primary mode or the only modality of hand hygiene, you could be spreading C. difficile without realizing it. It does require soap and water to kill and to properly clean the hands. More efficacious than alcohol-based hand rub. Preventing contamination of the hands via glove use remains the cornerstone for preventing Clostridium difficile transmission through the hands of direct care providers. And after the gloves are removed, one should practice hand hygiene with soap and water. If your institution experiences an outbreak with Clostridioides difficile or C. difficile, use only soap and water for hand hygiene when caring for residents with a C. difficile infection, and alert your health department. In Pennsylvania, in 2018, there were over 7,000 cases of community onset C. difficile and more than 4,000 cases of hospital onset C. difficile, to a total of more than 11,000 total C. diff cases in Pennsylvania alone. So a significant burden of disease. Okay, this slide discusses the environmental cleaning that is required to eradicate C. difficile from the environment. You must use a disinfectant with a sporicidal kill claim listed on the EPA K list, so that includes bleach. If you are going to use bleach, it's a 1:10 ratio with 1 cup of bleach to 9 cups of water. The surfaces should remain wet for 10 minutes, which is the contact time for bleach. You want to allow the surface to air dry. The standard quaternary ammonium disinfectants are not effective against C. difficile spores. So I think you can see that the environment of care can quickly become contaminated with all of the pathogens we discussed today. Care providers, residents, and their visitors can then contaminate their hands by touching the contaminated environment. And then when they touch the resident or their colleague through handshake or back slap or whatever, they can spread the infection. Cleaning and disinfection is important to eradicate this organism, but it has to be done appropriately. So if you know you have norovirus problem or you know you have C. difficile problem in your facility, you must use appropriate disinfectants. Also, you want to focus on the high-touch items when cleaning your environment. We're going to talk about this in a moment. All right, so this is a schematic to show you exactly what I just said in words. So a contaminated inanimate surface through direct transmission can infect a susceptible patient. Likewise, a contaminated inanimate surface can then contaminate the hands of the healthcare worker. And if hand hygiene compliance is not good, so 50% or less, can then be spread to a susceptible patient. So this table is difficult to read, but it is a really for your reference, and it lists the common disinfectants as well as some new decontamination technologies such as hydrogen peroxide, which has a shorter contact time than quaternary ammonium compounds or bleach. So right here, improved hydrogen peroxide has a 30-second to 1-minute bactericidal, meaning it kills bacteria, and virucidal, meaning it kills viruses. So in facilities where they have to turn over, let's say, clinic spaces or emergency rooms quickly, this would be a product that they might want to consider using. Also, it would free up your environmental cleaning team quicker because it only takes up to 1 minute for the surface to remain wet with the product. Okay, so another important thing to mention is that cleaning requires the use of friction or elbow grease, okay? Cleaning is different from disinfection. Cleaning requires a detergent or soap and water, scrubbing and elbow grease to remove visible soil. This precedes disinfection. A low-level disinfectant from the previous table would be required to disinfect the surface, and you should use only EPA-registered products. Follow the manufacturer's recommendations about the amount of product needed, the dilution required, and the contact time to remain wet on the surface. This is very, very important. If it doesn't remain wet on the surface for the proper contact time, it will not kill the organism. Also, the safe use and disposal of the product will be in the manufacturer's instructions. You might want to consider some options for evaluating how well your environment is being cleaned. So this will help you to determine if your cleaning staff or your cleaning company is doing a good job. So the easiest, this is from the CDC, and the easiest of these methods is the fluorescent gel marking. So basically what this is somebody goes in and marks the items in a room, such as the bed rail and the, the commode and things like that. And then the person goes in and cleans, typical cleaning job, and then you go back in with the UV light, and everywhere that fluoresces is an area where the cleaner missed cleaning. So it can give immediate feedback to the worker that they have to go back in and clean the items that they missed or didn't clean well. This is the easiest and cheapest of all of these to do. Another method is ATP system. This is adenosine triphosphate, which is a unit of energy in all living cells. This system is based on, you need to purchase a luminometer, and it counts the relative light units from the ATP molecules that are left behind after cleaning. So this is more expensive than the fluorescent gel. It's a little bit more difficult to do, but again, it gives us on-the-spot feedback to the cleaner or the staff that are doing cleaning that they miss spots. So if you choose to monitor how well your environment is clean and disinfected with either a fluorescent gel and black lighting or the ATP monitoring, you want to focus on their high-touch items, such as the light switch, the sink handles, the phone and the call buttons, the bed controls, the toilet flushing, chairs, bed rails, door handles. All right, now let's talk a little bit about hand hygiene. Hand hygiene is critical to reducing the risk of infectious disease transmission. The options include alcohol-based hand rub or soap and water. Alcohol-based hand rub, in general, should be the primary mode of hand hygiene. This is a recommendation of the Centers for Disease Control and Prevention and the World Health Organization. In studies that compared plain soap and water to antibacterial soap and alcohol-based hand rub, these were experiments where they contaminated a person's hand with bacteria that you could find in the environment, such as Staph aureus or gram-negative bacilli like E. coli, or a yeast species such as Candida. And then they did colony counts of their hands after using alcohol-based hand rub or the various soaps like plain soap or antibacterial soap. And you can see that the odds ratio was lower for alcohol-based hand rub, meaning it was less likely that the hands were contaminated with alcohol-based hand rub after alcohol-based hand rub. Also, studies have been done looking at ring wearing, and they showed that there was a 10-fold higher median skin organism count if a direct care provider was wearing rings. And there was a stepwise increased risk of contamination of the hands as the number of rings worn increased. And that odds ratio for one ring worn was 2.6, so That was a 2.6 times increased risk that the hands would be contaminated, versus greater than 1 ring worn was almost 5 times increased risk. So let's review the advantages of alcohol-based hand rub. So we just showed it's more effective against a broad spectrum of pathogens. It does increase the compliance with compared with soap and water. It requires less time than soap and water. It's less irritating in general and less drying to the skin. Pardon me. And it facilitates hand hygiene at the bedside, so no need for sinks. So when to use soap and water? So the exceptions to alcohol-based hand rub include when hands are visibly soiled, after caring for patients with known or suspected C. difficile or norovirus, like we explained before, if exposed to Bacillus anthracis or anthrax, which I hope that never happens, before eating and after using the restroom. And the Centers for Disease Control has this very cute poster that there are 1 trillion germs can live in 1 gram of poop. Wash your hands after using the toilet. And you can download these from the CDC website. So you can put those in the restrooms in your facilities. The hand washing technique, you should wash your hands for at least 15 seconds, not specifically 15 seconds. And you need, again, to use friction. Wash your hand when you wash your hands, just like when you're cleaning the environment. The time it takes is less important than making sure you clean all the areas of your hands. So that means between your fingers. What are some barriers to effective hand hygiene? So we do know that hand washing agents can cause irritation and dryness. This is sometimes a barrier to getting direct care staff to do proper hand hygiene. If sinks or alcohol-based hand rubs are not conveniently located, or there's a lack of sinks, this can be a barrier. Lack of soap and paper towels, so basically lack of hand hygiene supplies in the direct care areas, that's a barrier. If your staff are too busy or have insufficient time to perform hand hygiene, so that happens if there's understaffing or overcrowding of residents. So those are barriers. If a patient or resident's needs have not been made a priority, that can be a barrier. And also, some people have a perceived low risk of acquiring infection from patients and residents. And that's misinformation and miseducation. So they need to know that there is a high risk of acquiring infections from residents and patients. Also, a lack of a system for replenishing hand hygiene supplies. So who is responsible for replenishing your hand hygiene supplies at your facility? Do you know who to call for those items? Okay, so what are some selection factors for hand hygiene agents? So, of course, the efficacy of the antiseptic agent, which we talked about previously. So alcohol-based hand rub is more efficacious in most instances than soap and water. You want acceptance of the product by the healthcare personnel or direct care providers who are going to be using it. The characteristics of the product, skin irritation and dryness, and accessibility of the product throughout the facility, and the dispenser systems. If the dispenser systems are broken, then it doesn't matter that they're full, right? So you need to find a product that your healthcare workers or direct care providers are going to use, that they'll accept, and that it's accessible and readily available in where they're going to be using it, and that the dispensers are functional. Okay, let's talk a little bit about respiratory etiquette as we approach respiratory viral season, pathogen season. So respiratory etiquette applies to any person with signs of illness, including cough, congestion, rhinorrhea, or increased production of respiratory secretions. So what should facilities do? They should provide tissues and no-touch receptacles for disposal of those tissues. They should provide resources for performing hand hygiene in or near common areas. And they should offer masks to coughing residents and other symptomatic persons, such as visitors. Staff who are ill should be sent home, and they should not be working. So you need to educate the staff on the importance of infection prevention measures to contain respiratory secretions to prevent the spread. So respiratory etiquette involves coughing into your arm or elbow and not into your hands, because if you cough into your hands, you've now contaminated your hands. Additionally, some facilities will restrict visitation to only visitors who are healthy during respiratory viral season. So if they'll have signage in their front, lobby saying that if you are sick, please don't visit. So it's recommended that you post signage to remind everybody to cover their nose and mouth when coughing and sneezing. Again, cough into your elbow, such as shown on this CDC poster. You want to use and dispose of tissues. The signage should remind people to use and dispose of tissues appropriately, and then to perform hand hygiene after hands have been in contact with respiratory secretions. So you want to have ample supply of your alcohol-based hand rub throughout your facility, and including common areas, so where people dine, where they congregate for social reasons, and the lobby, whatnot. So what is personal protective equipment, or PPE? So PPE is wearable equipment that's intended to protect direct care providers from exposure to or contact with infectious agents. It prevents the transmission of microbes to healthcare workers and other patients. It includes gowns, gloves, face masks, face shields, or goggles. And the selection of the PPE is based on the type of patient interaction and the potential exposure to blood, bodily fluids, or infectious agents. But in order for PPE to be effective, it has to be used properly. Do not reuse PPE. Do not disinfect gloves. Do not use PPE if it's damaged. Do not substitute hand hygiene for glove use. Do not touch your face with gloves on, and dispose of gloves properly. Donning and doffing of PPE appropriately will help prevent contamination of self. This slide also is from the CDC, and it shows the proper sequence or steps of putting on, which is donning, and taking off, which is removal of personal protective equipment. This is to avoid contamination of self. You want to always follow removal of PPE with hand hygiene immediately. So you can download these from the CDC website and help educate your direct care staff. So when to change gloves. So if you're in the middle of working with a resident, you want to change your gloves if your gloves become damaged. If you've moved from a contaminated body site, now you need to perform something at a clean body site. So for instance, you've just helped, let's say, a resident with toileting, and now you need to handle perhaps their catheter site or something such as that. You want to always work from clean body site to a dirty body site so as not to contaminate the gloves for clean tasks. You also want to change your gloves if the gloves look dirty or have blood or bodily fluids on them after completing a task. So then you would remove your gloves and clean your hands appropriately. So either with alcohol-based hand rub or soap and water if the patient has C. difficile or norovirus. So always, always, always clean your hands after removing gloves. Dirty gloves can contaminate hands upon removal. Next, I'd like to mention briefly some things about employee health. You want to encourage your staff to receive an annual influenza vaccination and to practice meticulous hand hygiene, which is incredibly important during respiratory viral season. You also want to encourage them to practice excellent cough cold etiquette and do not come to work sick. I would recommend that they require a physician's note in order to return to work, such that the physician has, or a physician's designee, has said that this staff worker is ready to go back to work. You want to educate your staff on hire and re-educate annually about the importance of hand hygiene and the importance of excellent environmental cleaning and disinfection. For vaccination of direct care workers, the CDC recommends that in order to prevent the transmission of disease, all direct care workers or healthcare workers should receive the measles, mumps, rubella vaccine, a hepatitis B vaccine, and in fact, OSHA, this is an OSHA regulation that an employer requires to offer hepatitis B immunization to employees who will come in contact with blood and bodily fluids of residents or patients. If an employee refuses hepatitis B vaccination, a declination letter must be placed in that employee's file, and they should be counseled that they are not protected against hepatitis B. Likewise, direct care workers and healthcare workers should receive the annual influenza vaccination. It's a Healthy People 2020 goal to reach 90% compliance with vaccination. Direct care workers and healthcare workers should also receive the varicella vaccination. All of these vaccines will decrease the chances that staff will become ill with these pathogens and spread it to their colleagues or other staff, residents, and their own family members. So in conclusion, I'd like to remind people that during winter season, respiratory and GI viruses, C. difficile and group A streptococcus are more common. Infectious outbreaks are common in group care settings, such as personal care homes and assisted living facilities. Good infection control processes can prevent the transmission of these agents, and practicing good infection control is your professional responsibility. Become a hand hygiene champion, meaning you should model good hand hygiene throughout your facility for all your staff and the residents. Obtain an annual influenza vaccine and encourage others to do so too. Thank you.
All right, if anybody has any questions they'd like to submit, please go ahead and do so. At this point, we don't have any yet. But I thought maybe I would bring up a topic right now that just came to mind of TB in long-term care settings. There's been a little bit of a debate as to whether one is more or less likely to be exposed to TB if they're in the community or if they're in a group setting. I know I'm putting you on the spot with that right now, but I thought you might know a little bit about that.
Yeah, so congregate setting and in enclosed spaces is a higher risk in general for acquiring tuberculosis because there's not as good airflow as if you were outside of that facility. And sometimes with extremes of age, people can reactivate latent TB infection and develop TB disease. So it's not infrequent that we'll hear about TB outbreaks in long-term care facilities or congregate settings. And I believe, like in Philadelphia, where I also practice, we've had a lot in the last 5 years in long-term care facilities. We've had about 7 outbreaks of TB. So it does happen.
Okay, well, that's helpful. All right. Well, I guess we'll hang on for a couple minutes to see if any questions come through. It's been a great topic to talk about, especially this time of the year. So
yeah, getting ready for the winter respiratory viruses and stuff. So, and you know, the Centers for Disease Control has said that influenza is going to probably come earlier this year to our country based on what happened in Australia with an earlier flu season for them. So I would recommend trying to get your flu shot as early as possible. It does take about 2 weeks to get protective antibodies. So in the interim, use meticulous hand hygiene and clean the environment well.
Okay, yeah, we're just going to wait a couple minutes. Don't want to have dead air here. Dale's here. Dale Crow's here. I'm sure he could entertain everyone a little bit.
Sing a song.
Well, you wouldn't want to hear me sing, but if you do have any other questions later on, obviously call the hotline. We'll try to help you out that way too.
And that number, for anybody who doesn't know, is 866-503-3926. I mentioned that early on, but in case you didn't get it. And the email address, which goes right to Dale, is ra-pwarl headquarters at state.pa.us. We can talk about credits.
Well, as usual, this is a 1.5 credit course or webinar. You will not get a certificate, but if you were signed on for the duration, you can take 1.5 CEUs for the webinar.
And that's for personal care home and assisted living residents, administrators alike. This topic really relates to both types of facilities equally. The infection doesn't discriminate.
Yes,
the
that's
CDIS
correct.
doesn't discriminate between different facilities.
Yeah. And so the slides will be also available, correct?
Right. We
have
the slides available. They're attached to the webinar today. You can find them in the handouts on the webinar. If you're unable to get it there, I'm sure you could email Dale or give him a call, and he'll send it to you either on the hotline or the resource account email address I just gave.
Well, maybe no one had any questions.
Right? Well, that's a good indication that it was a good presentation that covered everything that was needed.
And they can email you with questions if they think of something that.
Sure.
Yeah, so just let me know and I can help answer.
Right. If you have any questions about today's presentation, go ahead and send them in call Dale or email the resource account, and we'll forward them on to Dr. Gould. Of course, there's a lot of information available on the Department of Health and the CDC website.
Yeah, and the CDC has great posters and handouts, trifold brochures and things like that for all of this, for cough, cold etiquette, for hand hygiene, So during winter season, it's really great for a facility if they can just download those posters, put them all throughout the facility in common waiting areas like the lobby and whatnot, and put the respiratory etiquette station right in the lobby. And I think that sends a really strong message to visitors. Visitors could be, clergy, it could be family members, things like that, to perform good cough, cold etiquette, to not visit if they're sick, how to perform good hand hygiene, things like that.
Yeah, that's helpful. And about a month ago, I was asked to forward out I think it was an influenza toolkit from the Department of Health, or infection control toolkit. That's available on our website as well. But if you're interested in receiving that, if you didn't get it earlier, let Dale know and we'll get that out to you as well.
We don't have a newer influenza poster, do we?
No, the influenza poster is the same, the one that's required to be posted year-round in the facility to let residents know about the availability of flu shots.
Mm-hmm. Yeah, that is the single most important thing you can do to prevent transmission is to get vaccinated. And then good hand hygiene.
Yeah, and I hear a lot of people say, thank you. Looks like we got some questions, but I was just going to say, I hear a lot of people say that they never got the flu before, so they're not going to get a flu shot. Why should they get a flu shot? That's their excuse for not getting one anyway. And I know there's a lot of reasons why somebody might not get a flu shot. But the fact that you never got the flu before probably just means you're lucky that you didn't get the flu before. So getting a flu shot is definitely your best bet.
Yeah, and these respiratory viruses like influenza, I mean, they're everywhere. You can go to the grocery store and push the cart, and the cart handle can be contaminated. And, you know, so you just never know when you're going to come in contact with it. So.
Okay, well, the first question that came through, I'll just start reading them. What does the evidence indicate regarding care workers with long fingernails or painted fingernails that will disguise visual uncleanliness?
Yeah, so the evidence shows there have been a lot of outbreaks, especially in neonatal intensive care units, linked to artificial nails and the little jewelry decorations that some people like to put on their nails, harboring things like Pseudomonas and other bacteria that can then cause infections in the neonates. So it really is recommended that a direct care provider, first of all, not wear dark nail polish because you can't see the dirt under the nails, right? And to only have the nails a quarter of an inch above the fingertip, no longer, and to not use those little gems or stickers that they sometimes put on nails to, you know, it's like arts and crafts, right? So, you know, to not use those.
What do they call that?
The acrylics?
Yeah.
Yeah.
I guess I can't remember what they were called.
Yeah, so just, you know, chipped nail polish too can harbor more germs. There's lots of evidence out there for that. So it is a recommendation. And in most hospitals have policies about not wearing, well, first of all, not wearing rings, not wearing, you know, not having long nails, not wearing dark nail polish. So clear nail polish or pale pink or a color that you can see through to see the dirt under the nail. Yeah.
Okay, that's helpful. There's a question as to whether the recorded webinar will be available, and the answer is yes, we will have that on our website with the other webinars eventually, as soon as we get a copy and we can get it uploaded to the website. That's available. I don't have the web address off the top of my head, but our website under the personal care home section, under training, you can access the webinars. Next question, can you offer any guidance on MRSA, especially in the nares versus blood or urine?
Okay, so MRSA, so methicillin-resistant Staph aureus is a drug-resistant form of Staph aureus, and it can cause both local and invasive infections. Now, if it's just in the nares, then the person is asymptomatically colonized, like a carrier, okay? Those people can, that is sort of the first step that's required before you get infected with MRSA. You have to be colonized with it first. So there are situations where if a facility is having a problem with MRSA infections, that they might try to screen all of the people in that facility or the unit and see if they're colonized with MRSA. You can do things to eradicate MRSA colonization, just like you can eradicate group A strep carrier state. And that would involve either systemic antibiotics or antibiotics like in the nares, like a topical antibiotic, or in the rectal area. You can use chlorhexidine gluconate baths to eradicate it from the skin. So there are things you can do to eradicate the asymptomatically colonized person. And this might be something that a physician might suggest prior to surgery. Let's say a person's going to have open heart surgery and they're known to be colonized with MRSA. They can take those measures to try to eradicate the colonization prior to the surgery.
Okay. There's a question that's more regulatory here. Is it permissible to have residents stay in their rooms if there is influenza in the facility until the typical incubation period is over and no other residents have symptoms?
I would say that that should be something they should discuss with their local health department. And if the local health department is not helping them with that, then they should discuss it with the state health department, who can give them direct guidance about that. And I think it probably depends on what type of facility they're calling from in terms of like how much space do they have between, you know, patients. Some places are very, very cramped with residents and stuff, so.
Okay. There's a question, it says, please review the outbreak statistics in Pennsylvania again. Did you have, it just says outbreak statistics.
I'm not sure what they mean by that. You mean the slide? They don't specify like influenza or norovirus?
No.
Yeah, I'm not sure what they mean.
Okay. And the same person is asking for more on TB, the TB topic. But I think that was before we talked about it.
Yeah, I think a lot of people in the United States think that tuberculosis is gone, and it's not.
Right.
So we have about 9,000 cases of TB disease a year in the United States. Luckily, the numbers are decreasing, and they're decreasing in our state, and they're decreasing also in the major city in our state, which is Philadelphia. So that's all good, but it still causes disease. We have, you know, about over 200 cases in the state a year. Oh, wait, is this the? Let me see if I can go back. We could have a whole separate talk on tuberculosis.
Yeah. Maybe we can cover that next time.
Yeah, let me see if they'll just, maybe, ooh, a lot of slides. Is this what they were referring to, you think?
This says outbreak in Pennsylvania.
Well, okay, so Pennsylvania is not listed as one of the states in this paper. But you can see that there are a lot of outbreaks from influenza and norovirus and C. difficile, and less from strep pyogenes, luckily. So I'm not sure. I did mention that for norovirus in Pennsylvania, I did have some, I don't have it on a slide, so maybe that's what the person is referring to. We had, in Pennsylvania in 2018, we had 127 outbreaks of norovirus with over 3,000 cases. So maybe that's what the person wanted to hear again?
Yeah.
Maybe. Okay.
Right. Okay. Question, how do we prove we earned CEUs if there's no certificate? It's just important to put that on your training record and just keep track of that.
They could also print out the slides.
Right.
That sort of proves that they attended, right?
We have an electronic record of everybody that signed on to the webinar, if we would have to use that. But, you know, it is kind of an honor system that you signed on.
Okay. Can you please direct us to where to get the poster that's required that I just spoke about? That is on our website. If you go on our BHSL page, and if you're not sure where to find that, please get a hold of Dale and he will let you know, or he'll send you the poster. It's available on our website under, I think, miscellaneous information.
Yeah.
So. Okay, and the person who wanted the statistics are saying it's the TB statistics they're asking about.
Oh, the one for our state?
Yes.
Yeah, there are a little over 200 cases, I believe, last year in Pennsylvania. And in Philadelphia, we have close to 80 cases a year. So we're the big contributor of the state cases. So most of the cases occur in non-U.S. born persons or in people who have a non-U.S. born contact. So a child whose parent, let's say, was born outside of the United States, or the grandparent, something like that. About 10% of the cases in Philadelphia are pediatric. Yeah, I could give a talk about TB if you think people would like to hear that.
Yeah, that might be a good topic for a future webinar. All right, well, that was the last question that I had. So I think we can conclude there a little bit early. So, yeah, once again, if you have any additional questions, please contact the operator support hotline. We'll make sure we get answers for you. Or if you need the PowerPoint or any of the information we talked about today, just give Dale a call or email the hotline resource account. And thank you very much for joining us today. I hope you have a great remainder of the day, and we'll see you next time. Thank you.
Thank you.